He holds the Harold and Shirley Lederman Chair in Psychosocial Oncology and Palliative Care, and is the head of the Department of Supportive Care at the Princess Margaret Cancer Center. He's the director of this exciting new center, the Global Institute of Psychosocial, Palliative, and End-of-Life Care, UTEC, and is also, of course, a professor of psychiatry at the University of Toronto, and is a clinician investigator who has published widely on psychiatric and psychosocial aspects of cancer and medical illnesses. He has a huge reputation that's so exciting, hence our full room today, and there'll be many people who are going to be watching it online as well. I just wanted to also say that Gary has been a fantastic friend and leader in our Institute for Life Course and Aging, including being the interim director in past years, and had designed and implemented the the palliative option within the specialization. So we're really delighted to have you today on the topic of death anxiety. Thank you.
Great, thank you very much. Thank you all for coming. Some of you may have seen the newspaper again yesterday and today about the first case of assisted dying. It's an interesting phenomenon. Maybe we could talk a little bit about that. It's a serious matter, of course, assisted dying, although it feels to me something like Beatlemania. There's the degree of interest and excitement about this I think it's a sociological phenomenon that we could actually probably think about why this has emerged as such an important issue, and also what it reflects or what it represents is also interesting to think about. And that's sort of what I'd like to talk about is how we manage the problem of mortality. Most of the world's religions and philosophies are organized around this problem of mortality, about the end of life, and what happens at the end of life, what happens, as we were talking about, after the end of life. It's something that we've struggled with within medicine and within the related fields, I think. And of course, I think that what accounts partly for the cultural phenomena that we're seeing right now is the demography, is that we have a shift of the population, that a large proportion of the population now are concerned and preoccupied with the end of life. So that's what I'll try to talk about now. What are the costs of this in terms of how we manage it or don't manage it? And I hope, I'd be pleased if people have comments or questions along the way so we can have kind of a conversation. These are the words of Philip Roth. He said, in every calm and reasonable person there lies a second person scared witless about death. I would say that's true to some extent, but Philip Roth was not a young man when he wrote that. He's older now. But I think this has something to do with what people call mortality salience. So growing older, as you grow older, the issue of mortality looms larger. When you become ill, the issue of mortality looms larger. We all know it in the back of our mind. If you think about it, if you're 20 years old and if I ask you what are your plans, and when you think about how long you're going to go to graduate school for, and everyone actually has an implicit timeline. If you were going to live to be 500, actually when you finish your PhD might not be as important. So we're all thinking about what the timeline is, but of course when people are ill, it is in the front of their mind and activates many different kinds of concerns. That's what I meant by mortality salience. And of course being diagnosed with an illness like pancreatic cancer, and lung cancer, ovarian cancer, these things bring the question of mortality very much to the foreground. And it can be fatal, actually, this awareness. This was, I think, an alarming study. It's a Danish study where they have very good epidemiological data. That 1 week after the diagnosis of cancer, there was a 12-fold increase in the risk of suicide, 3-fold increase in the risk of cardiovascular event, and it was, whereas suicide in general, as you may know, is more common in men than women. In this case, there was no difference. And the risk of both of these things were still elevated after 1 year. Why are these people killing themselves, would you say, in that first week? Yes?
They want to avoid the suffering part of their disease.
So it's a kind of short circuit. It's a fear of suffering. Yeah, it is a short circuit. It's probably not that they're suffering at the moment, because if it was due to actual suffering, you would expect the risk, to go up as the disease progresses. People some of them may not have any symptoms at all. So these people are frightened, and I think these people suffer. If you made a diagnosis, it would be an acute stress disorder. It would be many of them were suffering from. And I think this overwhelming anxiety and autonomic arousal is probably what counts for the risk of cardiovascular death at the same time. Now this is a whole subject in itself. Does this have anything to do with the way in which we manage this, the way in which news is communicated? Do we train health professionals about how to communicate news, about how to support care? As you may know, care tends to be medical care, cancer care, for example, tends to be heavily organized around the disease and the medical parts of care, and much less around the person. And because I work in cancer, I'm going to be focusing a lot on cancer, but actually, cancer is just a model. I had before worked a lot in other diseases, and this is just a model. The problems are not unique to cancer. They have to do with any life-threatening disease. So these are some of the things we fear. You mentioned suffering, which is one of them. People will fear helplessness, being helpless, losing control. There's a sense of loss. Think about it, if you were to find out you only had a year to live, about all the losses, present and future, that you might have to face. The question of the meaning of your life. One has to call into question the meaning of one's relationships, one's activities. There is the fear of physical suffering. In the press, when we read about assisted dying, that is what we read most about, I think, is the fear of unbearable pain. Being a burden to others, and the fear of non-existence. When people talk about legacy, what you leave behind you, whether it's in your accomplishments, in your family, in your name that might be on a building or on a plaque somewhere, this has to do with what terror management theorists call symbolic immortality, that we experience a sense of living on, and religion have a way of experiencing both literal, of helping us to experience both literal and symbolic immortality. Is anything left out? Does anybody want to add to that list of what we might fear? So how do we manage this? How do we master mortality? And that's sort of what I wanted to think a little bit about in different ways. How do we what are the ways in which as a culture and as an individuals we face that? Anybody have a thought about that? About some of the different ways as individuals or as a culture, or how any of you think you manage it? Yes?
Avoidance.
So we don't... Although there's an interesting thing, that sometimes what we call avoidance or denial, as people have said, is actually to do with a hyper-awareness. In other words, if you have people who are frenetically engaging in certain kinds of activities, in the case of the cancer, it could be pursuing all kinds of clinical trials, but it's what a midlife crisis is in a way, where one seems to be denying mortality, but of course one is acutely aware of mortality. But that is one of the common strategies, but here's the problem: it's actually easier to do when you're healthy. That most of us don't. It interferes with your functioning if you're all the time thinking that you're going to die. It's hard to be here or anywhere else, and we can usually successfully put it out of our mind. However, if you have a cancer and you have pain and you've lost 20 pounds and you look different when you look in the mirror, it's very hard to do that. Reality doesn't permit avoidance, and that's one of the reasons we see a lot of distress and why people need help. Yes?
I was going to say carpe diem, but not just because for joy, like living for the day, living for the moment, but also just living for whatever you have.
So that's one of the ways we manage it. In fact, Erik Erikson, wrote a lot about adult development, talked about mortality as a psychic organizer in a constructive way. That because we have a timeline, because time is not inevitable, it puts some pressure on us to make us life more meaningful now. It's sort of why that expression comes, youth is wasted on the young, because young people somehow don't really realize that, even though it's true for them. Also, life is not infinite, even if you're 20. But yes, that is another way we manage, is trying to make life more meaningful in the present. Any other thoughts for that? Yeah.
The slide says mastering, but you said managing. Is there a reason you used the word mastering?
Well, yeah, there is. Do you have a thought about those two words?
They're different, but
Yeah.
just want to hear your thoughts on it.
I'll say a little more as we go along, but to me, managing I think of managing as a humbler word, that we can't get rid of this problem, and so how do we live with it, actually? Whereas mastering is sort of more the idea that we're going to overcome it, actually. Yeah. Yes?
I think it's investing a little bit more in the next generation that you're going, but your offspring are still here.
That's this kind of symbolic immortality in a way. We get to live on through our children, through our accomplishments and things like that. Yes?
Storytelling.
Yeah?
life stories.
That's how we create meaning, actually, isn't it? That is how we manage. Creating narrative creation is one way of managing things that are traumatic. Did someone else have a point? Yes.
So understanding and humbly engaging it,
Understanding and what?
and humbly engaging mortalities, but it's
Yes.
part of the
Yeah,
story.
which is connected, I think, to
Yeah.
narrative formation. Yes. Yes. Does someone else have? Yes.
And really examining what you lived. I found that incredibly important. Like going through my memory box, and now I'm shredding it all, but to relive it, to really see what you did do, it's amazing. You don't remember.
You know, yes, and by the way, this is one of the problems, you know, at our hospital, we see, of course, cancer more commonly occurs in older people, but it does occur in younger people. Meaning making is much harder for younger people, and there's more than one reason for that. It may be a developmental capacity that one develops as one grows older, is a capacity to find meaning. But there's also a cultural phenomenon, which is that in our culture, people, like many of the young people here, are actually in a state of preparation for life, often until, let's say, the age of 30, right? So much of what we're doing now is about preparing, getting a PhD and all the things that one might do, or a master's degree, all the things one might do. It's so that meaning is created in a forward sense. So if life is interrupted, it's very hard to look back and say, to look back at all the things that you found meaningful. If you're 70 years old and you've had some satisfactions in your life, it's a much easier thing to do. So that is a problem for younger people. I think that's more stressing. But let's talk about this difference between managing and mastering mortality. In line with some of what you were saying, we're talking about narrative creation, and to what extent does verbalization, does talking, does connecting with other people about these things help? Now, if you ask, you know, until recently, people thought you could not talk to patients who were seriously ill, cancer patients or other people who were seriously, you could not talk about this. In many parts of the world, that's been very common until recently. In the Middle East and Asia, people talk to the family and not the patient. When you actually ask patients what they want, both with early stage disease and later stage disease, patients actually prefer communication that is open, honest, timely, that does include a discussion of life expectancy and prognosis, and involves them in taking into account who they are. I think, you know, of course, communication gets a bad name, because, of course, if it's done unempathically or insensitively, it, of course, is very problematic. But people want to talk about these matters, because, of course, everyone is thinking about them. Anyone who's diagnosed with cancer almost reflexively begins to think about, will I survive? And we found you don't actually have to do a lot. I'll talk a little bit about this later, but we've constructed this therapy that we've developed and are testing and are disseminating for people with metastatic cancer. But this is Chloe Shaw is a qualitative researcher who does what's called conversational analysis, looking at the sequences of conversations and the effect, the contingencies. And what she found was death talk came up in the first session just by creating space. You didn't even have to ask these people these things. You just needed to ask open-ended questions and create that reflective space. Because this is what's on people's minds. This is what they're worried about. This is what is urgent. And the therapist, of course, needs to be willing to do that. Now we get asked the question, to what extent does that come up in cancer clinics? This is a study, Pollock did this study, videotaping oncologists in cancer clinics, and she identified what were called empathic opportunities. So these were moments where a patient made a statement, you know, followed by a pregnant pause, where the patient said, I've got nothing to look forward to, ... So how often do you think the oncologist would have responded to that? People guess. What do you think?
I said 0.
What do you mean?
Not often.
Not often. I probably loaded the deck by asking the question that way, but they responded only in 22% of cases. Most of the time they changed the subject. Now, you could ask why do you think they do that? Why do people not respond? Yeah.
They're not comfortable in what to say.
They don't know what to do? That's part of it, yeah. Yeah.
We're totally trained to cure. Anything less than that's a failure.
Right, so they may feel it's a failure, yeah.
I think it's just practical, time constraint.
They worry about time. If I open up this conversation, is it going to take an hour when I only have 15 minutes? Yes.
Discomfort with the patient's emotions.
Yeah, which means discomforts with their own emotions,
Yeah.
right?
Yeah.
Because it fits with what you were saying, but it's an uncomfortable thing that someone says to you with lung cancer or serious cancer, I've got nothing to look forward to. There's no way you can take that away. You can't say, don't worry, it'll be all right. It's someone used the word humbly before, but it's humbling for both the oncologist or the therapist, and even as a therapist with these people. What I've said is that if I had someone, a young person would come to me as a therapist, we could both have what I call positive illusions. The idea that you have this set of problems, and if you come to see me, I'll help you so that your life will be satisfying and meaningful. Now, in reality, neither of us have a guarantee that will work out, that will happen. We have a possibility that could happen, but we could at least both entertain that idea. Right? Whereas, if someone has one of these serious cancers, actually, you can't do that. You can't say it's going to be all right. What's going to happen is your disease is going to get worse. Your symptoms will get worse. And not only are you going to die and suffer from that, but I am too. Like that, I'm going to have the same problem sooner or later. It's a problem that's my problem as well as your problem. So one has to be able to tolerate that, right? It's as opposed to thinking, don't worry, everything's going to be all right. Now, oncologists think it would take too long. I think they're wrong, in the sense that I think responding empathically to that will have a calming effect on the patient. I don't think it inevitably. I think people can also tell the patient at what their time limit is. I think it actually is possible to do in a short period of time. I think it results in a better outcome. But I think it's actually better for the oncologist. Here's an interesting phenomenon. People have talked about compassion fatigue. Do you know this term? And people think that it comes from too much compassion. I don't know, do people think it does? We think it comes from the opposite, actually. That it comes from not being connected with the patients. Seeing people, in other words, who are going through trauma, feeling that, not having any time to process it with the patients, and not having any time to process it yourself either. We think that's what accounts for this syndrome of burnout in health professionals. And oncologists, it's high. I think because they see a high volume of people who are seriously ill in these brief moments, these brief unprocessed moments. We think they have a misunderstanding of what might be causing it, actually. It's the opposite of what they might be thinking. And there is some suggestion, actually, that emotional connection and altruism are actually as helpful for the donor as they are for the recipient. That our brains are hardwired that way, that our reward centers in our brain get activated when we respond and feel altruistically towards other people. And so it's a kind of misplaced strategy or misdirected strategy, I would say, to think that I'm protecting myself by remaining disconnected. Did you have a thought?
No, I'm just pointing out one of the names there.
Which name was it? Yeah, Rob Buckman was someone who was a colleague of mine, and we did this together. He died a couple of years after. But he's someone who he was a world authority on this whole question of communication. He's written a number of books and many papers on that. Now, you might say, well, okay, that's the old school, that we're now accepting medical students, for example, and differently. We have different criteria. But this kind of review of research suggests actually that medical students and residents get worse over the course of their training. That we admit people to medical school who have the capacity for empathy. Not surprisingly, because these days that is a fairly people's interpersonal qualities and humane qualities are important. So why does that happen, do you think? Why would they get worse rather than better? You know that? Or have you observed that also, by the way?
I think there were earlier studies that talked about the hidden curriculum.
Yeah. People know what that means, what people are referring to?
Just the modeling.
So as opposed to what's written in the books as to what you should do, is what people observe.
Yeah.
So you might get a lecture in medical school on something. I got no lectures that I remember anyway. And I had hundreds of hours in the anatomy laboratory, but I don't remember a single seminar on how to communicate with patients. But even if nowadays they do, but if you are in the clinic at the bedside and that isn't what you see observed, you come to learn that isn't what's important. And also you don't get a chance similarly to process what you're going through. And so it becomes problematic. Now, in fact, the evidence suggests that people can get better. People, for me, I think of this as similar to musical or athletic ability. That people differ in their innate capacities for communication and empathy. just as they do in music and in athletics. But all of us can get better with training. And it's kind of odd when we think how important communication is in medicine, and that's the one thing we haven't trained doctors to do. We train them in everything else. No one asks someone to go do a lumbar puncture or a physical examination or any procedure without training them properly. But we do ask them to communicate with patients without training until very recently. So, about mastering mortality, that's one of the ways we try to master mortality, is curing the disease. And it's a very noble endeavor. Who could be against that? And a lot of money is invested in curing disease. There is sort of a when I went into psychiatry, for example, I started off in internal medicine. I did a residency in general internal medicine, but when I went into psychiatry, people said, well, how could you go into psychiatry? You don't cure anybody. And if you think about it, it's such a fundamental misunderstanding of medicine that so little of medicine is about cure. We do cure some infectious diseases, and we cure now childhood leukemia and some other diseases, but if you think about a large number of cancers, diabetes, strokes, heart disease, neurological disease, the large majority of medicine is not about cure. The large majority of medicine is about prolonging life and improving the quality of life. But it is a very appealing idea. A large amount of our research dollars go into that problem. And if you see how, this is how hospitals tend to advertise, including Princess Margaret where I work. Conquer is maybe slightly more ambiguous. They would say it's not just conquer, it's not cure. Do you take conquer to mean cure? Or would you read that as something different?
Cure.
You think it means cure?
Yeah, that the way it is there, yeah.
Some people think it's meant to mean something more ambiguous, like conquering the symptoms, conquering the disease, conquering the stigma. But I think it plays a lot on the idea of cure. It's a very appealing idea to people. I mean, the idea that you could be cured is a much more appealing idea. Now, it's been a bit of a losing battle. I mean, there have been gains made, but there is more cancer occurring than ever before. Most of this is due to the demographics. Cancer is largely a disease of aging. So because people are not dying nearly as much of heart disease, people are living longer, and infectious disease are living longer, and you're more likely to die of cancer. Age is the biggest single risk factor for cancer. It's a bigger risk factor than smoking, actually. So don't grow old. And of course, this is a huge problem in the developing world, as this is normal, but this shows you the increase. By 2030, the number of cancer cases is expected to increase globally from 14 to 21 million. Cancer deaths from 8 to 13 million. And 50% of cases are expected to occur in lower and middle countries. People present late there. And there, not only do they not have modern, they don't have many medical treatments that we might expect, they also have very poor access to palliative care and access to morphine and other pain-relieving medications. So cure is not liable to be the solution. And certainly in the developing world, when you have so many people presenting late, we need means of treating cancer, of management, and maintaining quality of life. So chemotherapy is effective, radiotherapy is effective, surgery is effective, but the question is posed as to what is the benefit of aggressive cancer care near the end of life. Now, in a paper like this, in the Journal of Clinical Oncology, aggressive cancer care near the end of life is actually a euphemism for inappropriate cancer care. Getting chemotherapy in the last few weeks of life, having an ICU admission in the last month of life, having an acute hospital admission are really all taken to be examples of poor care. They're more likely to occur when there isn't advanced care planning, when there isn't a discussion of the goals of care, when there isn't palliative care introduced. And this study, published in 2011, actually said that it was increasing. They found it in about 22% of people, but there was a progressive increase with each successive year of multiple emergency room visits in the last month, ICU admissions, and chemotherapy in the last 2 weeks of life. So we need a balance, right, between aggressive and appropriate medical care and the early introduction of palliative care and a discussion of advanced care planning. There's a medical sociologist from San Francisco who wrote a book called The Time to Die, studying how end-of-life occurs in a general hospital. And what she referred, how she described aggressive care in this situation is she described it as a train that keeps moving. So that there is just another trial and another round of phase 1, phase 2 chemotherapy trials, rather without the question being unpacked. You know, what is the nature of the disease? What are the goals of care? What is the likely benefit of treatment? I saw one in my office who had metastatic ovarian cancer with metastases to the liver, and in the course of the conversation, I used the word incurable, and she burst into tears because no one had used that word with her. So she was receiving chemotherapy for an advanced and progressive disease, but no one had clearly talked to her about that. In fact, the goal of this was perhaps to shrink the tumor, perhaps to prolong her life, but she has a disease which was incurable. Now, you actually can't make informed decisions about these kind of treatments unless you understand something about what the disease is and what the treatment is likely to accomplish. This study shows the benefit. There's another study like this, a larger study from our center. Camille Zimmerman conducted a study of early palliative care, randomized controlled clinical trial showing that people who received early palliative care had better quality of life, better satisfaction of care than people who had usual care. This was published in The Lancet. This was a smaller, earlier study by Jennifer Temmel. 150 patients randomized with non-small cell lung cancer. And what she was hoping to find was that these people had better quality of life, they had less depression, but what the surprising finding from this study was that these people lived longer. So the people getting early palliative care compared to usual care lived longer.
Why? Why?
Well, that's a good question. Do you have a thought?
Because maybe they're less, they feel heard and they feel less anxious?
That's a possibility. It's possible that they had more meticulous medical care, because palliative care doctors may have attended to their general medical condition. But those people got also less chemotherapy. So now, every day in my office, or every week in my office, anyway, someone says to me, I need to have, me or my family feel I need to have another round of another clinical trial, even though I have advanced disease and it's a phase 1 trial, because I don't want to give up hope. People believe that they will live longer if they get chemotherapy, whereas in fact a study like this shows near the end of life, you actually might live a shorter time with more chemotherapy, because these are toxic drugs, and people who are ill don't tolerate them well.
There just seems to be this assumption that palliative care means we're not going to do anything.
Yes.
And it's such an unfortunate label that
The word, you mean?
yeah, the word, and or maybe the education of people to actually know what we mean when we say palliative care. I just wonder if you think that there's anything.
Well, there is a debate and
educate
discussion
that.
about this name. You know, the word palliative, do people know who coined that term? It was a Canadian. It was Balfour Mount, who was a surgeon who studied with Cicely Saunders in London, St. Christopher's Hospice, the first modern hospice. He coined that term as a new term, which he came from the Latin, which he coined because he thought the word hospice had stigma. It was associated with poor and indigent people, and so he formed the word palliative, and it was meant to refer largely to end-of-life care. We now use the term palliative to refer to, and the World Health Organization uses the term to refer to psychological, physical, social, spiritual care for patients and family from the beginning of a life-threatening disease through the course to the end of life and in bereavement. So we mean it, we use it in a different way. It does require education, you're right. Some people want to change the name because they think it will be more acceptable. Other people think we need to educate people more. The people who are most bothered by the name are usually the people that have more advanced disease. And I don't know, my sort of feeling often is that people think it's the name that's the problem rather than the thing that's the problem. And you're afraid of the name because of the thing.
Do you think the big sign on the front of PMH that says "Conquer Cancer" is really the problem?
Well, you see
it sets up a win-lose situation, and when you have winners, you have to have losers de facto, and I wonder if that contributes into the excessive chemotherapy.
There can be a comfort everyone feels in focusing on cure. Is that what you mean?
Well, people don't give up. I've got to do that round of chemotherapy. I've got to conquer this. I've got to. They've set it.
Now, one of the things
framework up as a failure versus a success.
One of the things that we've had, however, at our center I think Camille Zimmerman had a lot to do with it in terms of her trial of early palliative care, is that now palliative care does get introduced early. And although we do have to explain the name, our actual problem is being able to keep up the referrals and make sure our waiting list isn't too long. So we have more referrals than we can manage, actually. Because human beings are much more sensible than you might think. And once you explain to people that the palliative care team are actually experts in symptom control and management and planning, and that you will continue to see your oncologist together with this team, people are actually very open to it. I almost never have anybody refuses that kind of referral once it's explained to them. And the people most upset about the name are the people whom we need to talk most about the problem of advanced disease, in my experience.
I have a question related to that. So there's this analogy, like this war analogy. I think that might be what you're referring to. Winning the battle, losing the battle. You hear it, in different situations, and conquering, like that is some kind of war. And I actually don't like that analogy, but it comes up a lot. I'm just wondering, is there work on it? Do people?
Yeah, there has been some qualitative work on it. Many people don't like the analogy. I have less problem with it if it's the patient's metaphor, because many people do experience it as a battle, as a fight, as a struggle. I guess it's whose metaphor it is. Is it our metaphor that we're imposing on the patients, or is it their metaphor? If the patient experiences it that way, I don't know. But I can understand if we move away from this conversation and think how it is, people trying to manage their symptoms and carry on with their life. It does feel like a struggle. Think about if you're writing exams, that can feel like a battle too. But one of the problems is that all of what we're talking about may contribute to the cost of end-of-life care. That 25% of all healthcare costs are spent on patients in the last year of life. Some of this may be appropriate, but some of this is probably due to unnecessary health expenditures, inappropriate aggressive treatments. And so when people talk about whether we can afford more supportive and palliative care, I think the answer is yes. It's a question of what it is that we value and prioritize. That, of course, palliative and supportive care is the cheapest kind of care in cancer that's delivered compared to any of the other modalities. You think about the cost of expensive new drugs, radiotherapy, surgery. I don't know what one major cancer surgery costs.
It actually pales compared to the new biological agents.
Okay.
I know in colorectal cancer you spend something like $200,000 in the person's last 6 months of life, and 48 of it's on Avastin. And yeah, surgery's about $1,000, but major cancer operations about $1,000, unless it's lung, then it's about 30.
So, do you think assisted dying? Do you think this has anything to do with mastering mortality? The whole debate on assisted dying. Is this a way of taking control? She says, I'm old, I'm disabled, I support choice. So she wants to be in control of the end of her life. Now, as you know, it's controversial. It raises moral, ethical, legal conditions, but it still impressed me at how much of the population are interested in this. Now, I can tell you that the farther you are away from the problem, the more in favor you are of this. The people who are least in favor of it, for example, are the palliative care doctors. They're not much in favor of this at all. And at an arm's length, it feels like a much more important solution. If you read the newspapers, you would think that this is a major solution to end-of-life care, which of course it's not. Probably because human beings are hardwired, I think, the other way, that most human beings want to live as long as possible, which is why aggressive treatment at the end of life, it isn't only a doctor problem, it's a patient problem too. People tend to want to live as long as possible, yes.
Having talked to some palliative care physicians about this, I wonder if some of their perspective of this is that they're able to contribute to the quality of life at the end of life to their patients because they're providing the palliative care services. So I wonder if some of their difficulty that they have with this is related to that. Like if palliative care, good palliative care was available to every single patient, we may not need it. We may, some people would say that maybe the choice for physicians is to death wouldn't necessarily be as prominent in a way, just because they can, like that's one of the areas. I mean, I know it's more complicated than that, but I wonder.
I think many people feel that way, and I think that's a valid point. And in cancer, I think that's most of the time true. You could argue that in diseases like amyotrophic lateral sclerosis, which was the disease of the person who had it in BC, you might argue that's not true. That palliative care can't prevent the progressive paralysis and disability that comes from that. Yes.
Seems to me that the oncologist tends to be wanting to conquer. The palliative care has a different approach. And so I see potential conflict between those two. And I agree, I think we as community don't know enough about palliative care.
Right.
How do you deal with that apparent conflict between oncologists wants to push aggressive treatment, whereas better for the patient, as you showed earlier, some cases better not.
It's, by the way, of course, it's to do with all of medicine. All of medicine is, of course, much more oriented towards action.
Yeah.
We're all trained much more to do. I mean, we all feel more comfortable when we're doing. The oncologist will say, we had Malcolm Moore, who was the head of medical oncology at Princess Margaret, and he would say it's often, he's not feeling it's from him, it's often from the patients, he would say, that they're wanting him to do this. And actually, certainly at our center, we now have actually a much, I would say, a compatible marriage now between oncology and palliative care. Whereas people actually understand now that these things, A, can coexist, and that people need attention to pain and symptom control for one thing, to psychological suffering for another thing, and also increasing acceptance that many of these diseases we're not yet able to cure, and we're actually all involved in palliation. Yes?
Do you see the issues of pain and suffering and the lack of many effective pain medications as increasing a push towards
Assisted dying?
A push towards aggressive treatment? Because as my mother and I, for example, migraine is something that really is not effectively treated in terms of pain for millions of people who have such chronic pain, is the fear of it and then the reality of pain, maybe encouraging the push towards assisted death.
Well, I would say this is why palliative care, in cancer care, it's why palliative care and oncology need to coexist together. Because we need to be treating symptoms of cancer, but also cancer treatments, surgery, radiation, and chemotherapy all cause symptoms themselves. And so that if you have a program that's a center which is involved in treating people with advanced disease with those modalities, you need a strong palliative care team. Sometimes the symptoms are as much due to the treatment sometimes as they are due to the cancer themselves.
And would you say palliative care, or the concept and realities of palliative care have changed recently? Because my mother passed away 4 years ago. In long-term care, she would have been in palliative care in place had she not passed away at the point she did. That home is associated with hospice care. At that time, palliative very clearly meant very close to end of life. Has it expanded?
So there's been a huge ground shift, yes. And when we began, 10 or 15 years ago, specialized palliative care was unusual at our hospital. In fact, at the Toronto General, the Toronto Western, and Princess Margaret, there was one palliative care doctor for all three hospitals. So it tells you how little palliative care there was. And we now have about 12 or 13, and a palliative care unit and a residential hospice at the Kensington Health Center. And
That's where my mother was.
Right.
At Kensington, yeah.
So there's been a huge ground shift, and it's now become much more standard of care that medical centers are needing to provide. 30% of people, by the way, in Ontario die in chronic care, and we probably haven't paid enough attention to end-of-life care. Those are people who are more often elderly and more often have dementia. Yes?
I'd like to ask about hope. And when you, as a psychiatrist, have conversations with your patients, where does hope fit in? And do you try to foster hope? Or if they have hope, how do you address that if the prognosis is not?
It's a rethink. Yes, hope is a central part of what we do. It's a different way. It's a reconceptualization of hope. Medical people tend to think hope is about the prognosis in terms of how many months or years you have to live, and of course That is very important to the patient. But the kind of hope, the way in which we're able to support hope has to do with, as people were talking here about being able to create meaning in one's life, and for someone to feel understood, and their experience to feel known. Someone said to me after she'd gone through cancer treatment, I began to feel invisible as a person because everyone was focusing on some aspect of her disease or treatment rather than on her as a person. And I think there's something enormously respectful about spending time to be with the experience of someone who's going through that, which does engender a sense of hope. Yes?
On that theme of hope, my experiences around acute care and people dying in acute care, both parents that we've lost and as a bioethicist being bedside and that sort of thing, I really think that the cultural barriers that you're articulating, the ones that favor not aggressive treatment, but a curative model of looking at your patient, are huge barriers in really capturing people's wishes at critical times. And I do a lot of talking about advanced care planning, and so I use this story about my dad who died just shy of his 96th birthday and had many chronic conditions that, eventually overtook him. But I talk about the conversation about advanced care planning I had over a chicken dinner with him and how that pertained to the very end stages when he was decision making. But when we were decision making for him. But I also talk about the multiple admissions to acute care that he experienced and the number of times I asked for the physician or the nurse, primary nurse, to ask the physician to talk to my father, who was still capable, about his wishes, because his wishes were very clearly stated and he was still capable to do so. It took 4 admissions, and on the 4th admission he had an excellent discussion with his internist, which was just the model, I think, for a great...
This is about the train that keeps moving.
Yeah, it is. It's exactly what you said.
And without people being trained or supported to stop the train and have a conversation about what are the goals of care, what are the patient's wishes.
Do you know if there's a movement at foot to try and harmonize those concepts of curative and palliative in the acute?
Well, there is. Palliative care is a consumer movement, right? Palliative care did not arise from the medical community. It arise from patients and families who said, no, this isn't right. When my family member has a serious illness, we want attention to them as a person. We want control of pain. We want to plan. We don't necessarily want to end up in an ICU at the end of life. And assisted dying is the same thing, actually. It came not from the medical community largely. It mostly came from... and so I think it's been forced upon us, actually. And we find, certainly in our work, we find that our biggest supporters are patients and families. Anyone who's had a family member go through this once understands it. More sometimes than the medical doctors do, who tend to be maybe focused a little bit on the medical treatment part. Yes?
I'm not sure what you mean by a consumer movement. I understand the concept, but how can we still increase more palliative teams, more palliative physicians and other healthcare providers? How does the consumer do this? Does it come from the top or from the consumer? How
Well,
do
no.
we get
Well, I'm saying to you that
more people involved?
without a grassroots demand for this, it wouldn't have happened. I'll give you another example in medicine, which is obstetrics. The way in which babies are delivered. If you talk to someone who delivered a baby, 40 or more years ago, the father was not allowed in the delivery room. There was a whole way of doing that. Now we know it's quite different. A father who didn't go into the delivery room would be regarded as an odd person. That change didn't come from the medical community. That came from the community. It came from women and their partners who said, no, we want this to be done differently. Palliative care happened exactly the same way. So I think all the advocacy that you're seeing, I'm not advocating particularly assisted dying, I'm just saying that's an example of an advocacy movement. Palliative care is a similar advocacy movement. It's a grassroots global advocacy movement that only in the last 10 years has been incorporated into mainstream medicine, but it wouldn't have happened without that kind of grassroots support. So at the individual level, if you have a family member who has a serious illness, you have to ask about not just palliative care, but supportive care, psychosocial care, palliative care. And many more people we're seeing are now seeing this. As a psychiatrist, for example, people might have been ashamed to see a psychiatrist in this context years ago. Now we see people from the upper half of society seeking it out as part of high quality care.
they seek it out, but is it available? So like, are there more courses becoming
Well,
available? Are there things?
So it's 1,000 times more available than it was 15 years ago. And-
Not saying much.
No, but that just says that something could be done. We've got a lot of work to do, but I'm just speaking to the idea that nothing makes a difference is not true, that we've seen enormous grassroots. I'll tell you an anecdote which tells you about how stigma and attitudes have changed. There's a woman who's considered the grandmother of psychosocial oncology. Her name is Jimmy Holland at the Sloan Kettering, a wonderful person. She's still working. I was in New York on a Friday, and I was going to come see her. She said, "Don't worry, I'll be here till 7 o'clock." She's, I think, about 86, working till 7 o'clock on a Friday night. But she said in the 50s, they wanted to have support groups for women with breast cancer. So they wanted to advertise in the New York Times, so they called the New York Times and they would like to put this ad in for a support group for women with breast cancer. The New York Times says, "Fine, no problem, but you can't use the word cancer and you can't use the word breast." So they put in an advertisement for a support group for women with diseases of the chest wall. So this is technical. Yes.
Gary, the coexistence of oncology and palliative care that you're talking about, do you foresee that as possible with PAD and palliative care? How's that?
Do I foresee that as well?
Possible.
I think it's happening, you know. It's now, the American Society of Clinical Oncology now puts this as a guideline. I just was in Berlin, I spoke at the German Cancer Conference about this kind of thing. This is now seen as mainstream. 10 or 15 years ago, it would have seen as a little bit wild-eyed and radical. It's now mainstream. The way it is now is there's wide acceptance as this is the way it should be. And now everyone's figuring out how to do it. That's a very big change, actually. And if you look in the major medical journals, this is now part of mainstream medicine.
The mainstream is the oncology palliative connection. Is it going to be true for PAD and palliative care?
Well, that's much more controversial. I'll talk about it right now, but we're going to have to provide assisted dying because it's now legal. Many people think this is not part of palliative care per se, that it's an intervention, but it's not palliative care. I think you can make an argument for that. Some of the people may not be in formal palliative care either. I think the palliative care team will have to be involved. I'll say a little bit briefly about what we're going to do about it. And I'll have to be a little bit brief. Just to say that in spite of all this publicity, only a small percentage of people in countries where it's legal take advantage of assisted dying. Everyone wants it available. Very few people take advantage of it. And it is about control. This was Don Lowe, created that video. Why can't I control the circumstance of my dying? And this is partly the cultural phenomenon. The only people who, like us, who believe they can control the circumstances of their living, believe that they should control the circumstances of their dying. But we're not hearing this in the same way in Asia and Africa and other countries. These are the arguments, dignity and autonomy, and I think it has to do with these kind of, the demographics and these kind of values, that there's been a loss of medical authority. People don't think doctors alone should decide what happens. That's the power of the consumer movement. That, one time people thought the doctors knew everything, and now people don't simply accept that, especially about end-of-life care. The Oregon Death with Dignity Act was passed in 1997. It is about terminally ill people, though. It's more often university-educated people. The rate, this is the number of prescriptions and deaths, has been going up since 2015. Now you can see lots of people will take a prescription and never take the pill. And that's also about having this plan B. People like the idea that it would be available if they needed it. But even if the people get it, many don't take it, actually. And these are the reasons they gave. This is data that they're published from Oregon. It's not about physical pain, mainly. Right? Loss of the ability to participate in enjoyable activities, 73% loss of autonomy, 92% loss of dignity. Inadequate pain control was 29%, but those weren't even 29% included people who were just worried about that there would be inadequate pain control. So it's mostly, as in the case that just occurred, it's mostly about people's concerns about what will happen, or that they believe their present life isn't worth living. The Quebec bill preceded the federal legislation. It was for people with quote-unquote constant and unbearable physical or psychological suffering. But it was limited to serious incurable illness at the end of life. meant to have the physician there at the end. Now, the Supreme Court decision has been a little bit more open. They talked about a grievous and irremediable medical condition, including an illness, a disease, or a disability, cause of enduring suffering. So that's a little much more, I think that's much more open as to what it might include. It doesn't say that you have to be within 6 months of the end of life, and it doesn't exclude psychological disturbance or psychiatric illness. And there's now been this report to Parliament, the special committee, and they opened the doors even wider, actually. About a grievous and remedial condition, they included terminal and non-terminal, and they did not exclude psychiatric illness. That's very complicated, actually. But if you're now a doctor or psychiatrist, and a patient in the emergency department says, I want to kill myself, what do you do? Do you recruit them for assisted dying, or do you try to treat them? It's a complicated dilemma, actually. During suffering, but included physical and psychological. It opened the possibility for competent, mature minors. This could be done in children. And they talked about things that would have to be done: 2 independent doctors, witnesses, a waiting period. So now many people, I was just at a conference of lawyers, they were a little bit appalled that it was so open-ended. They think it will cause a lot of problems and controversy if it's such an open-ended thing, especially at the beginning. I mean, their recommendation as a group was that it should be limited to the last 6 months of life. We'll see. It's unclear what Parliament is going to recommend. Can you read that? We're now developing policy at University Health Network. I haven't lead psychiatrists actually put this together, but our approach is going to be to try to. The referring doctor will not have the attending doctor will not have an obligation to draw attention to the patient this is available, and to refer a patient who wants this. Patients may be able to refer themselves. We're going to have the assessment team be separate from that clinician. At least that's our proposal. This hasn't been approved. So it might include a psychiatrist, a consultant doctor, or palliative care doctor. It might include a social worker to assess things like competence, capacity, the nature of the suffering. Do they have pain that hasn't been treated that could be treated? Or are there financial concerns? Do they don't have a proper living condition that are contributing to their, or worry about burden on the family?
Gary, I can't see that from back here. Is that for the first request? You'll have a separate assessment team? Is that how you're writing it?
You mean as opposed to what? Do you mean?
As opposed to the first request going to the person's GP?
Well, the idea is you'll take it up first with your clinician, your attending doctor. You first discuss it, and then some people talk about this. It's like saying, I've had such a bad day, I want to quit my job. Yeah. But at the end of the conversation, you don't really want to quit your job. A lot of people most people might be in that category. A smaller number might have that persistent wish. In which case, yes, they would be referred to the assessment team. It would be separate. It would be an independent assessment. And we're going to have a separate, this isn't what we're doing, this is what we're proposing at the moment. It hasn't been approved by anybody. And we're proposing that the intervention team, the people who do it, be actually a separate group from that as well. And that there will be a specific protocol. So now, I just want to tell you, most people believe that there will be unbearable suffering at the end of life. I slipped over the slide, but we've shown, Sarah Hales and our group did a study of over 400 people with cancer, high access to palliative care. Most people had a very good quality of dying and death. It is possible at the end of life. Many people don't believe that's the case. We've also, there's your cat. We've also developed an intervention. We thought that psychosocial people haven't had an organized or systematic approach to how people with problems of advanced disease. There's a fairly predictable set of problems you will have. If you develop lung cancer, pancreatic cancer, or disease like that, you will have progressive physical symptoms. You might become unable to work. You're going to become, there's a requirement to become more dependent on other people. You might have been the caregiver to your partner, to your children. You'll now have to be able to accept help and support from them. You'll have to think about how you want to spend your life now, and are you, in terms of your relationships, your activities, or in a seminar like this, are you spending your life in the way that you want? And how will you face the end, and where will you want to be? And we haven't had an organized approach to help people deal with this. And that's what we developed and manualized. We called it Managing Cancer and Living Meaningfully, intending it to capture helping people with the practical problems of advanced disease as well as the profound existential problems. And what's unique about this kind of intervention is in a relatively brief intervention, about 6 sessions, it actually helps people address both and provides this kind of reflective space. Those are the domains: symptom management, changes in the self and relations with close others, spirituality, sense of meaning and purpose, thinking of the future, hope and mortality. This was actually one we've been from the beginning, we began to disseminate the intervention, and we found enormous interest. This was about 6 years ago, I think, was it? This is a group from Germany, Dana Farber. That's Colonel Zimmerman over there on the right, with the yellow black and the yellow shirt. On the left, the blonde woman is Anya Maynard, who leads a trial on this intervention now in Hamburg and in Leipzig. And we've had Joanna as a coordinator of our workshops. We have people from all over the world. We've done 3 or 4 workshops in China. People are very interested in how we talk to people about these kind of problems. And the closer you come to the patient, cultures are different, medical communities are different. The closer you come to the patient, the more similar are, in our experience, human beings, or these are universal human concerns. We've been doing funded research, funded here by CIHR, funded in Germany by German Cancer Aid. We've shown in our studies so far, phase 2 studies, significant reduction in depression and in distress about death and dying, measured out by Chris Lowell, psychologist in our group, and improvement in spiritual well-being. We're completing a large randomized controlled trial here, and similarly in Germany. Actually, our recruitment is finishing this week.
Tomorrow.
Tomorrow, if you believe that. And but we have the qualitative outcomes, which we actually rely on more from our own point of view. This has been the only opportunity for us to be looked at as people by the medical system. I think that's really important because you're more than the sum of your parts. I'm able to grow as a person. It makes me feel like I'll be able to handle death in a peaceful way. And it's significantly about creating reflective space, this kind of an intervention. That isn't what happens in a cancer hospital. Because we thought this might be redundant. We thought, gee, these people are seeing so many caregivers, so many professional caregivers, that do they really want one more person to talk to? But we found that everyone else they see is focusing on some aspect of their disease or symptom. And to me, it would be like parenting. Imagine if you had a child and all you did was talk to them about tasks, the jobs they had to do, and never talk to them about anything about what they were feeling or experiencing. That's what we do to cancer patients. And partly it's a function of simply time, volumes and time. This has allowed us to create space. Our hope is that this kind of thing will become more a standard of care. This is 6 sessions. So if you think about what a therapist who might be a social worker or a nurse or a psychiatrist, if you think of the hourly rate times 6, it's a very small amount compared to any other treatment that we would offer in cancer. So I'm going to stop. We're actually out of our time, and I'll end with a quote. It's about humility, which I think palliative care is about. It's from Leonard Cohen, which you're probably familiar with. There's a crack in everything. That's how the word gets in. That's the silver lining, the opportunity for growth that occurs when facing the problem of advanced disease, which is the human problem. So thank you all very much.
Thank you all. Thank you so much. That was a fantastic presentation, and to hear more about CALM. I'm aware some people will need to run to the next appointment, but would you take questions for a few minutes?
I have to run too, but I can just for a few more minutes if anybody else.
Okay, great. But we're aware that someone.
The slide where you address the power of conversation, how can I find that article?
The Buckman article, was that the one?
No, it was just you. It was.
That's a systematic
Rodin,
review.
2009.
Yeah, that was in supportive care in cancer.
Supportive care in cancer?
Yeah.
Okay, thanks.